Hi, I'm Debbie Innes-Gomberg, District Chief with the Los Angeles County Department of Mental Health, and I'm going to be presenting on our innovation programs. And let's see here. And I think most of you are familiar with innovation. Our innovation project in Los Angeles County is very similar to what you've heard in the last hour, and that is how to best integrate mental health, substance abuse services, and primary care services. And our projects are time limited. They started last spring, with the exception of one that's going to go to the board next Tuesday, but they started last spring, and they go through fiscal year 13-14, so they're time limited projects. The four models that we're testing out, and I'm going to talk a little bit more about the second one than I am about the rest, but I'm going to go ahead and go through each of these. The first one is the integrated clinic model, and this combines those three programs, so mental health, substance use, and physical health, in either a community-based setting where the primary care services are provided in the mental health setting, or vice versa, mental health is provided within primary care. And one of the hallmarks of this is that it had to be an integrated treatment team with an integrated chart. And I think, as San Diego and others have referenced, these providers are span some have electronic health records. If they do have an electronic health record, they're different companies, and then some still have paper charts. So that's been a challenge. The second one, and I'm going to talk a little bit more about this one, is the integrated mobile health team. And this is the closest to a full-service partnership program providing integrated care that I've seen. And so basically, this focuses on individuals who are homeless and who have a mental illness, as well as either a physical health condition or a substance abuse condition. And basically they use a housing first approach, so they get people housing immediately, and they use a street medicine approach. So there's an integrated team comprised of primary care, mental health, and substance abuse that does street medicine and does outreach actually on the street, engagement on the street, and services on the street. I had an opportunity to see Mental Health America's program in Long Beach, and it was really, really good, and something I think for this particular population of homeless individuals, very, very helpful. And again, an integrated treatment team, and they use project-based vouchers to support permanent supportive housing. And I'm going to come back to this in a moment, because as we were starting these programs last spring, we had an opportunity to get involved in the Care Integration Collaborative that Gail Bataille directed for CIMH. And so one of our partners, a mental health provider as well as an FQHC, joined CIC, as we call it. And so we'll talk a little bit about that. The third one is the community-designed integrated services management model. And so for 5 specific ethnic populations in LA County, we have 5 different models within what we call ISM, or the ISMs. And in each of the ISMs, the goal is to integrate mental health, substance abuse, primary care, and integrate non-traditional healing approaches, and as defined by each of those populations. I could spend 15 minutes talking about just that one, but so I'm going to go on. And the fourth one, which I'm not going to talk about today because it goes to the board next Tuesday, is the integrated peer-run model, which does contain a peer-run respite program, very similar, I think, in many respects to Santa Cruz's program. So maybe next year I'll get invited back to talk about that one. Let me tell you a little bit about the learning questions. And again, innovation is about learning. I consider it a learning laboratory, so we have questions. And the first one is, does integrated care produce better behavioral health outcomes? I think there's literature to support that, but we're going to measure that. Is there a difference in client behavioral health outcomes if the integrated service is located at an FQHC versus an outpatient clinic? We might find a difference there. And then, do models differentially impact client behavioral health outcomes? Very interesting. And what we might find with that one is it depends on the best practices that are used. We'll find that out, though. So in terms of evaluating integration, for the first time, with the exception, I think, of AB 34, which MHA did the evaluation for the first time we bid out the evaluation of our innovation program, and UC San Diego was the successful bidder, and so they created focus groups around October or September of last year. And so what I'm going to do is very quickly go through the process for evaluation of innovation. And the first thing that I think is going to be really important is the level of service integration. So for each of our partner organizations in these models, we're using the integrated treatment tool out of Case Western Reserve University. And some of you have heard me say this before, but it's probably the most comprehensive integration tool I've seen. And it focuses on organizational issues, treatment issues, and care coordination. And when you look at the instrument, I think not only will it help to understand where a provider is in the beginning and how the integration is progressing, but I think it will also act as a tool, a process tool, to help providers create that integration. Then we have a health status improvement, and UC San Diego has something called the PROMIS system, and so we're looking at global health measures there. Mental health status, in terms they're also using the PROMIS system, and it's an illness management and recovery scale, the clinician version. And so we have a substance use scale, also what they call the PROMIS system. We're going to evaluate client satisfaction, community satisfaction, probably via focus groups at some point. And then they're also going to do a cost-effectiveness analysis. We can have a wonderful program, but if it's cost prohibitive, it will not be replicable. And then what I wanted to show you next is a glimpse at the IMHT, that's the Integrated Mobile Health Team, baseline data. And in your packet, this doesn't come out nearly as nice as it does on the screen. And if you wanted more information or wanted to get this electronically, just my email is at the back of these slides. But basically, so far, we started the evaluation, or the provider started collecting data in about October, November of last year. And UC San Diego, in one of our quarterly learning sessions, just presented the baseline data at the end of January. So this is brand new. One of the things that we do with innovation is we do, and we stole the idea from CIMH, so thank you, quarterly learning sessions where we bring our providers together and we focus on what the data is telling us. And so far we've had two, and the focus has been on integration because that seems to be a real key to the success of these sorts of programs. How do providers integrate? And so what you see here for the Integrated Mobile Health Team is that about almost 67% of our clients are male, and which would make sense if in a homeless program that seems to be the case. And what's not clear on here, and it didn't come out well, is the ethnic breakdown. I'm sorry, the breakdown of, well, I'll tell you what that top right thing is in a moment. It didn't come out right. And then in terms of ethnicity, about 51% of our clients are African or African American, about 15% Hispanic, 28% white, and that includes Middle Eastern, Eastern European folks. And this, if you know homeless data, and particularly if you know homeless data in LA, this is pretty representative. And then a glimpse at, again, baseline data. In terms of these particular measures, they're usually measured on a 0 to 4 scale, and they vary in terms of whether higher means better or not. And I'm just going to refer to my notes, and I can tell you. In terms of the PROMIS physical health, it's a 1 to 5 scale with higher numbers being poorer outcomes. In terms of the choice, memory, psychosis, and strengths, it goes from never to always, goes back and forth in terms of whether the higher scores are better or not. And then the illness management and recovery scale is higher scores mean usually some more significant impairment. And then, actually, I'm sorry, higher scores are better. And then we're also using the milestones of recovery scale. And as you'll see here, especially on the right side, high-risk engaged clients are, for the most part, what the programs are getting at this point. So I think the average MORE score at baseline was a 3.25. So they're high risk, but they're engaged. And when we looked at the other models in terms of MORE scores at baseline, it was about the same thing, actually. So we have an engaged population, but they're high risk, as you would expect. And just to give you a sense of what we do with this data, at our learning session in January, we have storyboards, and so each model had a storyboard, and we presented this data, and then we asked some so everybody got into models, and we asked very specific questions that then folks would respond to, and because they were looking at their data for the first time. The data is also recorded, by the way. UC San Diego got a grant, and so they've given each provider a tablet, and you can record the data electronically, which I think has been quite helpful. Here is some more information. As you'll see here, and it's probably not a surprise, one of the questions is, has a doctor ever told you that you have 32% report diabetes, 64% high blood pressure, 45% high cholesterol, and then you get asthma and emphysema as well as hepatitis and other sexually transmitted diseases. And then the percent of clients screened for, 68% of them at intake had been screened for diabetes, 68% for blood pressure and recorded high blood pressure, and then you'll see the rest there. This was one of the models that they had some concerns about, that, how are we going to do these screenings in the field, in the street, and they've been doing a pretty good job so far. And then you'll see blood pressure and BMI as well. Interestingly enough, 40%, at least at baseline, had healthy BMIs. So we shall see if that continues or not. Early learning on integration. I'm going to start with the third bullet first, and that is that executive management involvement and support is critical. If you don't have the management's approval to do all of the things you need to do to integrate, you won't move forward. You must create an expectation that an integrated team is essential to your goals, and that meetings are mandatory. It's really easy to skip meetings. And if you do, you won't create integration. Our most successful providers do daily huddles to increase communication and integrated service approaches. Focused outreach engagement, and I think the pair that was in our CIC Learning Collaborative really focused on, if you do more focused and longer outreach and engagement, you'll get better results. They also found that peer advocates as ambassadors were really important, and to explore grants and other sources of funding to maximize the funding to diversify it. Changes that the IMHT provider group made as a result of the Care Integration Collaborative. The IMHT multidisciplinary team meetings changed from twice a week to daily with full team participation. And although I was not the LA County lead for that, I understand that took some time to do, but they did it successfully. And congratulations to them. And then second, the IMHT screening process ensured higher enrollment and housing rates when a comprehensive screening tool was changed to focus on a smaller number of clients and a longer period of engagement. So they got better outcomes. And my contact information should be on here, but I think it's in your packet. And I think I made it through in time. Thank you very much.